Yes. We want to review with you.
A, B, C, and D. And not necessarily in that order. Because I do want to review with you this morning. Miss B is
It's going to take time.
the last part of class to go over pediatric math with you. Yes, it will be on the test. There will be probably 4 pediatric math questions. Just be aware, you had to bring your IB book today, but I will give you the information that you need on the test for that, so you don't need to worry about remembering something about those ranges and things like that. Okay, but she just wants to bring your book so that you know how to look it up. All right, so we were talking about MS. And we were going over some of the drugs that you will see used. Now, skeletal muscle relaxants are not particularly a treatment for MS. They are a treatment for symptoms that you get with MS. Whereas the immunomodulators, the immunosuppressants, and the steroids act directly on the pathophysiologic process. What these do is act on the symptoms that those degenerative nerves have. Okay, a lot of times what you will see is major muscle spasticity. Okay, muscle spasms. And if you've ever had muscle spasms, you know how painful that they can be. Okay? So one of the things that you will see is that we will use baclofen or Lorisol or dantrolene or Dantrium and occasionally diazepam or Valium. Okay? Now, question that I got last test, and this is something you need to start doing. NCLEX will only have generic names. So on my test, the majority of the times you will see generic names because you have to be able to know what those names are. Occasionally, if it's not one that's in major use, I'll give you both. In fact, I think on this test I did. But just be aware that NCLEX only has generic. And the reason for that is that Canadian nurses now take our NCLEX. Because what they were having is that people that live near the border were either United States nurses were working in Canada and, those types of things. So we now take one NCLEX in North America. So whenever you're downloading the NCLEX test plan, make sure you don't download the French version of it. For those of you that don't speak French or don't live in Quebec. So just make sure that you are starting to learn those generics. Now, one of the things I will tell you is that these don't really make that, don't go with the rule, but the majority of times what you're going to have to do is learn these meds by classifications. Because if you don't, you're going to be a crazy person. 300 to 400 new drugs are released every year. I don't look at them and try to memorize those 300 to 400 different ones. What I learn is classifications. The classifications pretty much have the same side effects. They have the same therapeutic effects. They will have the same adverse effects. If you learn them by class, then you're going to make yourself less crazy when you're trying to do the study. Pharmacology can be up to 17% of your NCLEX. Because if you think about it, that's one of the major things that we as nurses do, is not only administer drugs, but teach about side effects and therapeutic effects and what you need to call the doctor about. Okay? All right, I'm off my soapbox. Muscle spasms. Probably the one that I see most often is going to be this baclofen. Baclofen and Valium suppress CNS, okay? But neither drug affects muscle strength. Sudden withdrawal can cause seizures and paranoid ideation. You know, that old saying, just because you think they're out to get you doesn't mean they're not. This is what you will see a lot of times in your patients when you cold turkey them off these medications. Now, if they suppress the central nervous system, what do you think one of the side effects of baclofen and diazepam are?
Respiratory depression.
They can be respiratory depressants. What else? Sleepiness. Sedation. Okay? You can have sedation, but no muscle strength loss. Dantrolene basically works directly on skeletal muscles, and it can affect muscle strength, but you do not see the sedation with this one. However, it can cause hepatotoxicity, okay, or liver problems. So if we have someone on this med, we're going to make sure that they've had recent AST, ALT blood work to make sure that their liver function is sufficient. Now, let's think about this for a second. If this one causes hepatotoxicity, what am I going to tell them not to take? No, not aspirin. Alcohol and or Tylenol. Okay? Same is renal. Okay? Mycins basically are kidney and hearing. Alright, so one of the things you need to think about is with those meds that are hepatotoxic, there can be cumulative effects. An occasional Tylenol is not going to hurt them. But if they're taking it on a regular basis, along with a skeletal muscle relaxant, then they may get into trouble liver-wise. Now, what are some of the other things that you need to teach these patients if they're on these skeletal muscle relaxants? Safety, definitely, because either sedation or because this one affects muscle strength, they may be weaker when they first start on that med. Don't try to lift. That's probably a good thing for everybody.
Constipation issues.
Constipation issues. If it is a skeletal muscle relaxant, then what you're going to see is a decrease in peristalsis. So increasing fiber, increasing fluid in that diet, stool softeners and or some types of bulk, like your Miralax, your Benefiber, your Metamucils are probably going to be good. Now, one of the things that I'll tell you guys, and this goes for pretty much everybody, okay, for us to form stool, we need at least 30 grams of fiber a day, and that's what the daily recommendation is. But what you will find is that most people only take about 10 to 12. Now, if you start someone on Metamucil 3 times a day to get their fiber content up, or you tell them to eat salads or cruciferous vegetables, like the broccolis and the cauliflowers and all of those nasty Brussels sprouts. Okay? What's going to happen when you increase fiber radically?
Diarrhea.
You might have got diarrhea, but you will have gas that will not quit. You will feel like if someone pokes your stomach, you feel like that balloon that goes in the air. Okay? What you need to tell these people to do is gradually increase their fiber. Otherwise, their gut is going to feel like, oh my God, please do not let me fart. Because I will definitely shart instead of fart. Increase fiber, because decreased peristalsis equals constipation. All right, again, baclofen and Valium, they suppress the CNS, they suppress and cause sedation. Okay? You can have dizziness. And that goes back to your safety issues. Okay? So you need to have them change positions slowly. Other therapies for MS. Typically, one of the things you will see, surgery is only performed if there is a severe spasticity or deformity. Sometimes what you will see is these spastic muscle contractions can be so strong that they can cause a contracture. And then often they will go in and do a tendon release and decrease that contracture so that there's a more functional limb. But that's not usually the rule. That's usually the exception. And typically what you will see is that's done in some of the later stages of these patients with MS. Nutrition and fluids. We want to maintain their weight as close as possible to their ideal weight for height and body type. Because extra weight that they're carrying around makes it more difficult to do transfers, makes it more difficult to do positioning in bed, makes it more difficult for movement. Okay? So that extra weight that they often will gain because the activity is decreased because of decreased functionality is actually a detriment. Now you want them not to lose weight too much if they're already at ideal body weight, because what else could happen? I've got this little skinny person that's not able to move very much on their own. Bed sores or ulceration, okay? So you're going to see that if you have a patient that is very thin, that turn Q2 may not be enough. It may be Q1. And very good skin checks on a daily basis. Dysphagia could become a problem for a lot of these patients the longer that they have MS, or sometimes with an exacerbation. So swallowing tests are going to be an issue. Most of your patients that die from MS don't die from MS, they die from complications. And aspiration pneumonia is going to be one of the problems that you're going to see. The other problem, of course, is going to be urinary tract infection. Rehab. Basically, what you want to see is that client to retain as much independence as possible by maintaining and increasing existing muscle strength. So PT consult for muscle strength, OT consult for assistive devices. If they're having trouble with balance A lot of times what you'll see is they will fit them with an orthotic device that will help allow them to have balance. They're having problems with their ADLs, like eating, dressing, drinking. Their assistive devices that can be fitted for them so that they will have a whole lot easier chance of doing that. And if you've ever seen some of the cups, we use them very similarly for our patients with spinal cord injury. Instead of gripping the cup, there's a handle that you just stick your hand through, okay, so that you can bring it to your face. And the little sippy spouts probably are one of the best things that have ever been invented, especially if you've got one of those Yetis with the handle on them. Those are really good because you don't want them too heavy, but you don't want them too light, because what happens is a lot of times they will go beyond where they need to be. Rehab is very, very important. Bladder dysfunctions. Now, with MS, if you get two, one of the things that you will see is that you will either have what they call a spastic bladder, where that you will have a bladder that will pee with just a very little bit of urine in it, okay? Most of our bladders have a capacity at about 400. That's normal bladder capacity without stretch. I would imagine that your bladder and my bladder, because we're becoming nurses, are much more than that, okay? But over that 400, that's what's considered normal bladder capacity without stretch. Most people will start feeling the urge to void at about 200. With your patients with spastic bladder, often what you will see is they will have that urge to void and will void it as little as 50 cc's. And those of you that have had babies and pee when you cough or laugh or do any of those things, and if you haven't gotten there yet, you will. I will tell you. That's sort of what happens, is that often you will see that these patients will have that urge voiding. They will know where every bathroom is in every mall and every store and every place that they go in because they scope them out. Okay? So typically what you're going to see is they will use anticholinergic medications. To help decrease bladder spasms. What it does is it keeps the bladder sphincter closed, and they're able to retain a more normal amount before they need to void. Now, the other problem that you get is bladder retention of urine. In other words, the bladder fills, but there's no urge to void. So we also get urinary retention. With that, typically what we do is intermittent catheterizations, or some of the latest technology is a bladder stimulator. It's like a pacemaker that's put into the bladder, and it's just set at a certain rate, and basically when that pacemaker fires off, the sphincter opens up and urine comes out. Okay? Not a cheap device. So most of the patients will do intermittent catheterizations. And I'll tell you, even if they do triggered voiding, okay, triggered voiding is like, you know, when you went to the pajama parties when you were young and you put the hand in the water and people peed on themselves, you know, when you were asleep. There's other ways to do it. stroking the inner thigh or right there at your butt crack, okay? If you stroke that, it will cause an urge to void. Try it when you're in the bathroom. Don't try it right now. Because I don't want everyone to run to the bathroom. But triggered voiding, what we teach them are some of those tricks, and then often what they will do is cap afterwards to make sure that they've emptied their bladder. Typically what we're looking for is a post-void residual of less than 100 cc's. Okay? If it's more than 100 cc's, then they probably need to go on a cath regimen every 4 or 6 hours. What we typically do is during the daytime when you're actively drinking, remember we want to push fluids on these folks because of decreased movement in the later stages. So they leach calcium, they're more prone to kidney stones. Okay? The other thing is that they're more prone to urinary tract infections. So intermittent cath before during the day, and then typically after 7 or 8 o'clock at night, we have them to decrease fluids so that they can go every 6. So that they only have to cath right before bed and then immediately on awakening. Okay? So intermittent catheterization. Now in the hospital, intermittent catheterization is a sterile procedure. At home, it is not. Typically, it is a clean procedure. It is a whole lot easier to teach someone to do a clean intermittent cath than it is sterile, especially if you're doing it on yourself. I used to have a patient that had spinal cord injury. I don't know how she could do it, but she could do it sitting in her wheelchair. And with no special movements or anything like that, she just do it. Go. Cognitive impairment. Remember, one of the things that you will see with this is because it is a demyelinating disease of the brain and central nervous system, you will have some problems with attention, memory, problem solving, handling distractions, visual perceptual problems. Okay? Remember, attention, problem solving, and handling distractions are more frontal lobe type issues. That visual perceptual problems is more of a parietal lobe. Okay? Because it is one of those things that looks at size, shape, weight, texture, and consistency. So one of the things you will see is that they may have a little bit of what we call brain fog. Okay? Typically, it's not confusion, but you will see a delay in processing, you will see a delay in problem solving, and sometimes you will see problems with, again, that emotional liability that we talked about with inappropriate laughter or inappropriate crying at different times. And it can just happen within a matter of seconds. This is a KDOD, guys. Fatigue is going to be your symptom that you're going to see no matter what type of MS that they've got. And one of the things that will contribute to fatigue is heat. You're going to want to avoid increases in body temperature. Patients that have a fever will have an increase in symptoms. Patients that are in this heat outside will have an increase in symptoms. To the point where if you are putting them in a tub or they're taking a tub bath, it needs to be tepid. No hot tubs or they'll drown because they will not be able to get out of that hot tub or that hot shower or hot bath because that rise in body temperature will cause that instant overwhelming fatigue. Okay? With patients that have MS, air conditioning in the summertime is a must because they will not be able to tolerate these high temperatures. Frequent rest periods is another thing, of course, if you have that fatigue. What's the difference between fatigue and being tired?
Be tired, sleep, fatigue.
Right, that's exactly right. Tired, when you're tired, you rest or sleep, it goes away. With fatigue, it doesn't matter how long you rest or how long you sleep, it is still there. Okay? And it's called nursing school. And working a full-time job and having a family. Okay? It does get better, I will tell you. It will just change. It doesn't always get better, it just changes. But frequent rest periods are very, very key with taking care of fatigue. And then avoidance of undue stress. One of the things that we see is that high stress periods often will cause an exacerbation. Okay? Other things that you need to think about is that it's really funny that we think of pregnancy as an undue stress, but one of the things that we typically see with women that have MS is that during pregnancy, their symptoms improve. However, after delivery, you can count on an exacerbation. Yes?
My mom had MS and she was paralyzed before. And as soon as she got pregnant with me, she was in
Yeah.
and then as soon as she had it, she went back to being worse than she was.
Yeah. And that is often the case. It's one of those things that we have no clue why pregnancy is sort of a immunization or a guard against those exacerbations. And that's one of the things that they're doing research on. But it's very, very interesting that with pregnancy, they can have a normal pregnancy and delivery with usually no problems. But it's in that postpartum period that you have to be very careful about watching that person. They need not only to follow up with their OB, but they need to follow up with their neurologist as well. Because it's about a 95% chance they're going to have an exacerbation in that immediate postpartum period. And think about that, they've got a newborn, okay? And one of the things that you cannot do with these immunomodulators, immunosuppressants, is breastfeed, okay? And you're going to have to not only have someone to care for that infant, but maybe care for that woman as well in that immediate post-op period because of that exacerbation. And they may have to be hospitalized for those strong steroids to treat that disease. Whenever you're looking at the nursing process with these folks, health history, physical assessment, childhood viral illnesses and stressors are also very important to look at. Well, you know, there's one of those things we don't know what really causes MS. It is an autoimmune disease, but what causes the trigger? There are some theories that say it's a viral illness that they had in childhood. Some say it's environmental factors. We really don't know. But typically we do go ahead and get a little bit of a history on those viral illnesses. diagnosis of fatigue and self-care deficit are pretty much standard for these patients, especially during an exacerbation. Now, when they're in remission, remember with that relapsing, remitting type of MS, they pretty much go back to normal or near normal after that exacerbation. I have a friend that's worked as a nurse for 20 years that has MS. And she still does bedside nursing. So she does have periods where she cannot work, but when she is not having exacerbation, she works bedside 12 hours just like the rest of us did. Basically, with cleaning, rest breaks several times a day to reduce that fatigue and for them to maintain that maximum level of autonomy. Think about this, guys. You've got someone, typically these women or people are diagnosed in their 20s, 30s, or early 40s. Okay, it's rare to be diagnosed with MS after the age of 60, but it does occur. Think about the type of psychological issues that they would have to deal with, because in your 20s, you're moving out from your parents. Some of us are lucky with that. Others, they may still be with you when they're 42. But anytime you will see they're gaining independence, they're coming up with their own lives, they're developing relationships, and you have this disease that's going to take away that autonomy. And so a lot of times what you will see is that it can cause depression, and they need to be treated with that, for that as well. Fatigue management and self-care deficit are very, very much key on your nursing care plan. What we want to do is look to see, does that client adapt their lifestyle to reduce that fatigue? Are they using their rest periods as appropriate? Are they taking their medications to decrease their exacerbations? Because remember, taking those immunomodulators, like the MABs, decreases the time of onset of disease to disability. And that's what we have them take those medications for. We want them to use assistive devices to optimize autonomy. So OT, PT consults are key for these folks. Okay. Questions about MS? Now, one of the things I would tell you is that I'm seeing a lot more patients with MS now than I did 20 years ago. And I don't know if it's something with the environment or what it is, but we're seeing a lot more. Yes.
What do you think whenever you say, it's in the PowerPoint a couple times, that it's familiar, but it's not?
It's familial, but not genetic. Okay? It's like it runs in families, but it's not genetically related. Okay? In other words, Aunt Susie may have had it, and Grandma Esther, but Grandma Esther, Aunt Susie, you, and have it. It's not genetic, meaning it's not passed down. Families have a predisposition. Okay? It's just like heart disease. Whenever you may have had, your dad had a heart attack at age 50, so at age 50 you're sort of tiptoeing around the tulips because you're afraid you're going to die from the heart attack too. Right now, we know that cardiac disease is related to environmental factors and lifestyle. Okay? But heart disease does tend to run in families because if you think about it, they're exposed to the same types of things, they're exposed to the same types of foods, they're exposed to the same types of beliefs and lifestyle. Okay? Familial means it runs in a family, but it doesn't mean that it's passed down genetically. Okay? And that's a very distinct difference. And you will see when we talk about muscular dystrophy, that one is genetic. Okay? Like Tay-Sachs or hemophilia, those are genetic versus physical. All right. Parkinson's disease. I'm going to spend a little bit more time on Parkinson's because you're going to see it a whole lot more often than you will see in this. It's a progressive neurodegenerative disease. It's characterized by tremors, muscle rigidity, and bradykinesia. Slow movements. Okay? Think about, how, I know none of you are young enough to remember the $6 Million Man where they always did, he was running in slow motion. But bradykinesia means slow movement. In other words, when I reach for something like this, it may be that it's slowed down and you're thinking, get on with it. But it's very slow. Okay? Akinesia. Akinesia means what? No movement. A lot of times with your Parkinson's disease, they have what we call freezing moments. And it's just like that YouTube thing they did a couple of years where everyone froze in their tracks. Okay? With your patients with Parkinson's, a lot of times whenever they're trying to get up or they're trying to walk, they will freeze in place because they don't have the ability to move. Okay? What you often see is postural instability. What does that mean? Well, they're like a weeble wobble. They tip and they often fall. So what you often see with your patients are those tremors. That's the number one key. And it is a resting tremor. In other words, when they're sitting there, they may have the shaking. It may be bilateral, it may be unilateral. But when they reach for an object, that tremor goes away. What you get is that neurons in the cerebral cortex are lost that specifically are dopamine receptors in the basal ganglia. Think of this. Parkinson's disease, PD. All right, that D, instead of standing for disease, think of it as dopamine. Parkinson's dopamine. Because that is one of your key. What you've got is you have dopamine receptors are either lost or they do not produce enough dopamine. We don't know the etiology of what develops Parkinson's disease. However, in this past issue of Nature, it's a science magazine, there's a study that they've done with something like 3,500 people, and they're sort of pointing to it's perhaps autoimmune. But that's one of the latest theories. We'll see. It does have 5 stages. And in that last stage, typically that's the terminal stage where they're bed bound and require a lot of care. Palliative care or hospice is definitely included in that last stage. Clinical manifestations, fatigue, slow movements, those tremors at rest, and you may hear them called pill rolling tremors because that's what they look like they're doing. They're rolling something between their fingers. Okay? Rigidity makes very active and passive movement difficult. A lot of times what you can see is that whenever they do move, it's a start and stop. And you may hear that called cogwheel rigidity. It's like the little gears of a watch that catch. Okay? who will get it. With bradykinesia, all of those striated muscles are effective, and it starts with their gaze. So often what you see is that their eyes appear fixed in their head because they don't have the ability to do those extraocular movements. And you often will see this face that has very little expression. Okay, if it helps you remember, think of it as resting B face. Because very little expression, because of the loss of that muscle movement. Often what you will see is because of that movement, you may have an open, slightly open mouth, and drooling can occur because they have the inability to close their mouth, and in the later stages, swallowing becomes much more difficult because of that striated muscle loss. They will have a loss of normal postural reflexes. In other words, what you will see is that whenever you push someone, normally they will sort of jump back and then come forward and balance themselves. With your patients with Parkinson's disease, if you were to push them, they would continue to fall. The other thing that you often see is that whenever you think about someone falling, what do we try to do?
Catch yourself.
Catch yourself. Okay? Patients with Parkinson's will face plant because they don't have the ability to bring their hands forward to try to catch. They just go face forward. Autonomic and neuroendocrine effects, many manifestations that facial lack of expression, or what we call mask facies, F-A-C-I-E-S. You may see eye problems. You often see constipation, urinary hesitation of frequency. Constipation is going to be a big issue with these patients because of that decreased striated muscle. Often you will see eczematous skin changes, and if you've ever seen sweat glands or eczema, okay, it looks like a reddened rash. You typically will see it on elbows or joints or arms, back of the neck. Typically, it's related to sweat gland activity from increased hormone production in the pituitary gland. These people will sweat a lot, and it's because of their Parkinson's disease. It's not necessarily related to heat. Though you put them in a hot room, they're going to sweat more. But you're going to see a lot of sweat, a lot of skin changes. And it can be very problematic because eczema can get infected and cause some difficulty there. Now, Parkinson's disease, we normally think of it as a disease of the older population, though it can be in younger people. Okay? You'll see, I think, on the next slide. Other manifestations you will see: depression and dementia. Now, one of the things often you find is that as they lose function, there may be some elements of depression. But Parkinson's disease itself will cause a depression because of dopamine, inability to use that dopamine that they've got, or the lack of dopamine. One of the things that you will see whenever we talk about psych is there has to be a balance of dopamine and serotonin for our mood to be what we consider normal. Okay? And with Parkinson's disease, because of that lack of or the inability to use dopamine, depression is a common manifestation. Later stages dementia, you will see as well. Bradyphrenia. Okay. Slow thinking or inability to form thoughts, plans, or make decisions. So if you really want to insult someone, call them a bradyphrenic pneumocephalic. So slow thinking airhead. But this is one of the things that you'll see with your patients with Parkinson's disease, and it's one of the things that you need to get used to, is that you ask a simple question, because remember we're using simple commands with these patients because of the slow thinking. They're unable to process two-step commands, like pick up your fork and take a bite of eggs is a two-step command. Pick up your fork. When they got the fork, scoop an egg and take a bite. Okay? So you have to give them plenty of time. If you're asking for a response, you have to give them a lot of time. It's not that they can't get the words out like your patients with aphasia, but their thinking is slow and it takes them a while to form a thought. Sleep disturbances. Typically, they have decreased ability to fall asleep and decreased ability to stay asleep, and that's because of the acetylcholine stimulation. So insomnia is going to be the issue that you're going to have to deal with. With your patients with Parkinson's disease, fatigue is not a normal part of the disease process like it is with multiple sclerosis. But if you can't sleep or stay asleep, fatigue will be an issue, as you guys all know. Typically what you're going to see, that muscle rigidity, okay, often will result in them unable to change positions. Depending on your sleep pattern, you may change positions at night up to 180 times. Basically, with your patients with Parkinson's disease, if they do fall asleep, if they're on their back with their arms crossed whenever they went to sleep, that's the position that they'll be in when they wake up, because they don't change positions. So you're going to see a lot of problems with skin breakdown and sometimes in your latter stages. Constipations due to that decreased peristalsis, immobility. Tremors inhibit drinking from glass. So if I've got my glass of liquid and it's doing like this, God help me when I open this back up. But what kind of drinking am I going to be able to do? None. Okay? Or I'm going to be wearing most of it. So typically what you're going to see is they will need cups with lids, with straws, or some other device, so that a lot of times what we've done is put a cup with a very long straw, like I would use with our spinal cord injury patients. They can't pick up the cup, but they can just lean down and sip. You know those hydro flasks that you wear? Okay, not the beer hat with the things, but the Hydro Flask. Those are good options for your patients with Parkinson's because you can just put the little tube and then suck on the tube and get water that way. Dietary changes from dysphagia. Okay, as I said, swallowing will be an issue with these patients. And a lot of them do die from aspiration pneumonia. So you've got to be very, very careful and make sure that you're doing assessments for that. All right, let's do 2 more slides and then we'll take a break. All right, we've talked about some of these things. Ocular uric crisis, you can see that she's got this gaze that's off to the side, the mouth is open. This happens occasionally in your patients with Parkinson's disease. We've talked about the bradykindesias or the achinesias. Speech is often slowed, and it is often very low amplitude. Okay? It's not that they can't speak louder. Sometimes in the later stages they are not able to because of vocal cord paralysis. But you need to teach them to sometimes take a breath and force that air out through the vocal cords so they can talk a little louder. Okay, speech therapy is very important with these patients as well. The forward tilt of the trunk and shuffling gait, okay, and it's propulsive at times. Remember when I was talking to you about gaits with your Parkinson's patients, typically their arms do not move when they walk. They have that shuffling gait, forward tilt, and typically it gets faster and faster and faster until they either run into the wall or they fall over. Okay? Safety is an issue with these patients when they walk. Falls, fractures are going to be problems. We talked about seborrhea, the eczema, excessive sweating on the face and neck. Typically, you see an absence of sweating on the trunk and extremities. Now, if I can only sweat my face and neck, and I can't sweat below, what does that put me at risk for? Ineffective thermoregulation. On these 100-degree days, I can overheat very quickly. Okay, because that's how we relieve body heat is we sweat. Postural hypotension. Okay, typically what you're going to see is a low blood pressure when they're sitting up. That is an effect of the Parkinson's disease. And also I will tell you that some of the meds that we put them on will contribute to that as well. So these patients definitely change position very slowly. Dementia we talked about, depression we talked about, social isolation. Some of it is self-imposed because I don't want to go out if my skin's all blotched and broken out and I'm sweating profusely and my mouth is hanging open and I'm drooling. But a lot of it is if I do go out and then have a problem where I have freezing or akinesia, I'm not going to be able to move and walk. So social isolation is a big issue sometimes for these folks, especially in those later stages of Parkinson's disease. gradual, typically after age 50, though there are some people with early onset Parkinson's. Mask, blank expression, stoop position, that pill rolling tremors. Alternate rest, and definitely what you're going to see is sometimes, especially in the early stage, whenever they reach for an object, then it's going to go away. Those tremors can also involve the diaphragm, tongue, lips, and jaw. It increases with stress. So if you put them in a stressful situation where they have to hurry to get dressed or hurry to get into the wheelchair, their symptoms are going to increase. Time is their friend. Bradykinesia, as we talked about, one of the things that you will see that's also very important is most of us blink anywhere from 30 to 60 times a minute. I don't know who was in on that study, but that would have been interesting, wouldn't it? But a lot of times with the patients with Parkinson's, they may only blink 5 times a minute, or not at all, especially in the later stages. So dry eyes are going to be an issue with these patients. That cogwheel jerky movement, okay? It's interesting, it rarely occurs in the white population. I have not looked to see the Hispanic population to see what the frequency is. A lot of times whenever you see Parkinson's disease before the age of 50, it can be the result of a medication. It can be the result of poisoning. Okay? One of the things that you don't want to do, if you don't know what you're doing, is to go to Lowe's and get the Rid-a-Bug and squirt everywhere, so that everyone is smelling the Rid-a-Bug and all of that. One of the things you will see is that exterminators with organophosphates or farmers with organophosphate poisoning because of treating crops will often develop early onset Parkinson's disease. Yes.
My patient last week, she was like 30-something, and she had been smoking marijuana whenever she was a teenager, so her mom sent her away, and they put her on antipsychotic drugs while she was in rehab or whatever. And since she's been, so for like 20 years, she started whenever she was 25, she's got tardive dyskinesia, so it's, you know, kind of similar. So she had a lot
Very
of,
similar.
yeah, so it was like Parkinson's, but yeah, so, which is really early.
Yeah. Just as an FYI, one of the things that you have to be careful about with teenage marijuana use, one of the psychiatrists that I work with basically said no one under the age of 23 should smoke marijuana because the frontal lobes are still forming, and marijuana can trigger susceptibility in those patients for development of schizophrenia and manic depression. So he basically says that, you know, for his patients of a consenting age over the age of 23, it will chill them out. So that might be okay for them, but he says that if you've never had a psychotic break with your schizophrenia, that casual marijuana use is enough to trigger in teenagers. Just FYI. As more and more states become legal marijuana. One of the things we're starting to see in Colorado is the increase in mental illness, as well as accidents. But it's going to be interesting to see what the 5-year break is. Okay, y'all take a break.